welcome to the first fill and happy holidays. This month is HIV/AIDS Awareness Month, so we're highlighting the critical role pharmacists play in improving outcomes for people living with HIV. From ensuring access to the right antiretroviral therapy to providing ongoing support and counseling, pharmacists are key in managing HIV care. Your dedication helps make a difference in the lives of those affected by HIV, so thank you for all you do. Before we dive in, I'd like to introduce my guests today, Katie and Nick. Katie and Nick, why don't you introduce yourselves?
Thanks, Yara. Hi there, everyone. This is Katie Meyer. I serve as the Senior Director of Content Creation here at APhA, and I'm excited to join Yara today.
And hi, everybody. This is Nick Bennett Brush. I'm one of the Education Fellows here at APhA for the 2024-2025 year. Good to be here.
Welcome. I'm excited to have you both. Today, in part one, Katie, Nick, and I will discuss the latest updates to the antiretroviral therapy, also known as ART, guidelines for adults and adolescents with HIV. We'll also discuss considerations in older adults, as fortunately, we have more effective medications, which allows people living with HIV to live longer. In part two, we'll hear from Kevin Astle, a clinical pharmacy specialist who will share practice pearls for optimizing care for people living with HIV. Let's dive into the updated ART guidelines by the U.S. Department of Health and Human Services. These guidelines, updated September 2024, provide essential recommendations to improve antiretroviral therapy management and treatment outcomes. While we won't have time to cover all of the updates today, we will focus on the key highlights and encourage you to review the full guidelines for deeper insights at clinicalinfo.hiv.gov. Katie, can you share with our listeners the most notable updates to the recommended initial antiretroviral therapy regimens for people newly diagnosed with HIV?
Absolutely, Yara. The guidelines were last updated in 2022, and research has certainly evolved in terms of initial combination antiretroviral use for people with HIV. First, dolutegravir, abacavir, lamivudine was previously recommended for most people with HIV, but the guidelines now recommend that it's only used for certain clinical scenarios, such as a concern about renal or bone-associated adverse events in which tenofovir disoproxil or TDF or tenofovir alafenamide or TAF would be contraindicated due to the need for HLA-B5 testing before initiating therapy. Potential for increase in the risk of cardiovascular events and availability of safer options. Second, several antiretroviral regimens were removed from the list of recommended initial therapy, including elvitegravir cobicistat and raltegravir-based regimens, boosted atazanavir-based regimens, efavirenz-based regimens, and rilpivirine TDF and emtricitabine regimens. These changes were due to these regimens having higher pill burdens, more adverse effects, or lower barriers to resistance than other antiretroviral regimens. For people who do not have a history of using CAB-LA as PrEP, the guidelines now recommend either bictegravir, TAF, and tricitabine, dolutegravir plus TAF or TDF plus emtricitabine or lamivudine, or dolutegravir lamivudine with some restrictions. For people who have a history of using CAB-LA as PrEP, INSTI genotype resistance testing should be performed. Darunavir cobicistat or darunavir ritonavir with TAF or TDF plus emtricitabine or lamivudine should be started pending the results of the genotype test, and then the regimen should be modified according to the results.
Thanks, Katie. Let's shift towards key considerations and recommendations when caring for older people with HIV. Nick, how do the updated guidelines address managing antiretroviral therapy in older adults, particularly considering polypharmacy and age related comorbidities?
Great question, Yara. These updated guidelines emphasize patient-specific antiretroviral therapies to address challenges like polypharmacy and age-related health conditions. Polypharmacy is a pretty major concern because many older adults already take one medication or more than one medication for other health conditions like heart disease. With antiretroviral therapies, there is a greater risk of drug-drug interaction, thus the guidelines recommend medication reviews regularly to minimize the risks. In terms of age-related comorbidities, we actually see that older adults with HIV are at a higher risk of cardiovascular disease, developing it about 10 years earlier than the general population. The REPRIEVE trial supports statin use for primary prevention, even in those with low cardiovascular risk, or particularly in those between ages 40 and 75. When 10-year ASCVD risk estimates are between 5 and 20%, the recommendation to start a moderate intensity statin like pitavastatin, 4 milligram once daily, is pretty strong. We also need to be aware of chronic kidney disease in this population. Regular monitoring and adjustments in ART might be necessary to decrease risk of worsening CKD. For example, tenofovir alafenamide is preferred over tenofovir disoproxil fumarate in renally impaired patients. Another condition to consider is bone health. HIV patients have a 1.5-fold higher risk of fragility-related fracture and a 4-fold higher risk of hip fractures. While this is not entirely explained by differences in bone mineral density, some ART regimens, such as those containing TDF or boosted protease inhibitors, are detrimental to bone mineral density. In short, the guidelines recommend monitoring for polypharmacy and focusing on medication regimens that treat age-related, non-HIV related illnesses that may be impacted by HIV regimens.
Thanks, Nick. This was insightful. Katie, the updated ART guidelines also talk about optimizing ART in the setting of viral suppression. What considerations do the guidelines highlight for managing ART in people who have achieved viral suppression?
Yeah, sure, Yara. Before I dive into the guidelines themselves, I want to first level set in terms of exactly what the term viral suppression means. So, essentially, viral suppression occurs when antiretroviral therapy reduces a person's viral load to an undetectable level. So, this doesn't mean the person is cured, and if the ART was discontinued, the viral load would likely return to a detectable level. So, considering that, because we now better understand HIV drug resistance, there are circumstances where it may be possible to consider switching a person to an alternative regimen that still maintains viral suppression without jeopardizing future treatment options. Reasons why we want to consider switching to an effective regimen includes maybe the patient's experiencing adverse events, or there's drug-drug or drug-food interactions, the patient becomes pregnant, cost, convenience, or they simply have the desire to simplify their regimen. Traditionally, people living with HIV who have no history of drug resistance or virologic failure can likely switch to any regimen that has been shown to be highly effective in people who are antiretroviral naive. One update made to the guidelines, however, was due to evidence that found that more people living with HIV are switched to regimens that do not include a nucleoside reverse transcriptase inhibitor, or NRTI, or only lamivudine. Because of this, the panel expanded the guidance to emphasize the importance of keeping regimens that contain hepatitis B active drugs for people with hepatitis B HIV co-infection. As evidence supporting use of long-acting cabotegravir plus rilpivirine has evolved, the guidelines now also offer that as an option based on data from switch studies and people who have challenges with adherence to oral antiretroviral therapy. So, major takeaways when considering switching an antiretroviral regimen for a person who's achieved viral suppression, it's important to personalize the decision based on what's best for their needs, and you should definitely screen for hepatitis B infection before considering an NRTI sparing regimen.
Great, thanks, Katie. And for our last topic of discussion today, Nick, why don't you discuss how pharmacists can play a key role in implementing these updates, particularly for populations with unique clinical needs?
Yeah, sure. So pharmacists are incredibly well positioned to optimize treatment regimens by tailoring ART to our patient's individual needs. We can review that regimen for potential DDIs, monitor for side effects, monitor renal or hepatic impairment, and help with co-infections like Hep B or TB. We also play a unique role in providing education to patients on the importance of adherence. We educate healthcare providers about ART regimens, and we help and reduce the risk of virologic failure by providing counseling to our patients and to those healthcare providers. By working within a multidisciplinary team, pharmacists can develop comprehensive care plans for patients that can manage complex cases like those we see in HIV infected older adults to ensure they receive personalized treatment for their disease.
Awesome. Thank you, Katie and Nick, for providing such valuable insights into the recent HIV treatment guideline updates. These updates underscore the essential role pharmacists play in optimizing care for people living with HIV. In part two, we'll focus on the unique challenges faced by special populations, such as older adults and those with complex medical conditions, so stay tuned. All right, let's summarize major takeaways from our time here today. One, special populations such as older adults and people with viral suppression require careful consideration of comorbidities and drug interactions. And our second major takeaway, pharmacists play a pivotal role in optimizing outcomes through counseling, education, and adherence monitoring. All right, folks, that's all the time we have for today. Look out for part 2 of this month's First Fill podcast that will release next Thursday, December 26th. Teaser will be speaking with Kevin Astle, a clinical pharmacist specialist dedicated to improving care for patients and fostering a stigma free healthcare environment. Don't miss it. For any AAHIV credentialed pharmacists, check out our recently released webinar titled Ending with HIV Epidemic, Pharmacists' Expanding Role and Impact, and our HIV PEP and PrEP certificate learning program that you'll find both in our learning library. And last but not least, don't forget to head over to the learning library at learn.pharmacist.com to earn your CE for this month's podcast. We'd love to hear your feedback on how you like the new setup. Take care and goodbye.